Hello, good evening, friends. Today I'm back, and today's topic, gestational trophoblastic diseases, is suggested by KMC Manipal PGs. This is one of my favorite topics because trophoblastic diseases actually gave me my first foreign trip. I won the UICC fellowship to visit Charing Cross Hospital, London, way back in 1992, and learned the management of trophoblastic diseases directly under the leadership of Professor Bagshaw, who is the Dean in management of trophoblastic diseases, as well as Professor Newlands. Let's not waste time. Let's just dive into the topic. That's me, Muralidhar Pai, Dean, Sikkim Manipal Institute of Medical Sciences, Sikkim. This is a very important topic, both from the point of examination as well as the practical day-to-day problem. When we say ydatidiform mole, it was because of Hippocrates who described it first as dropsy of the uterus. He found hydropic changes inside the uterus and he gave that name. The classification, when we say gestational trophoblastic disease, it includes everything. What do you mean by everything? Pre-malignant, partial or complete ydatidiform mole, invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, and atypical placental site nodule. But when you say gestational trophoblastic neoplasia, which is malignancy, you include the last 5 only. This is very important for us to understand. What is the risk of developing gestational trophoblastic neoplasia after having a ydatidiform mole or molar pregnancy? If it was partial mole, it is only 0.5 to 5%. If it was complete, then it increases to 15 to 20%. But you must remember, it need not be always preceded by a mole. The tragedy is it can occur even after a normal pregnancy and delivery. That's where we are actually caught unawares. The risk of choriocarcinoma after complete mole is 15%, as I have put up. Invasive mole is 3%. Epidemiologically, it's common in Oriental countries. Highest being in Philippines, 1 in 80 pregnancies, whereas in India, it is 1 in 400. 5 times less, I can say. But it is lowest in Europe, 10 times less, but the best studies have undergone there. What are the risk factors? Extremes of age, very young age and very old age. But this is not for partial mole, it's only for complete mole. Nulliparous somehow are at more risk. Previous mole, I have seen cases of 6 times molar pregnancy. But we need not scare the patient. We should remember that 98% of subsequent pregnancies will be normal. Even though moles can recur, 1 mole is not enough to scare her. However, the recurrence increases from 1:1000 to 1:70 and 1:7 if there are molar pregnancies in subsequent pregnancies. So that is dangerous. If it recurs, it keeps on recurring. But 1 mole is not enough to say that she's going to have 1 more mole. 98% of the subsequent pregnancies will be normal. This has to be kept in mind. Blood group A or AB are at slightly higher risk than those with type B or O. Consuming COC pill, about 50% more likely to get GTD, probably because of an abnormal ovulation that occurs after stopping this. You will soon realize when I talk about the mechanism by which molar pregnancy occurs, more prominent. Smoking and drinking alcohol. In any disease you take, these two are the risk factors. So also in mole. Having multiple sexual partners. Again, you will realize when I talk about the mechanism by which it happens, the dispermy, that may be the reason. So this is how it may happen through multiple sexual partners. Low socioeconomic status. Now I come to the mechanism or the pathogenesis of complete mole. We call it androgenesis. That is, mostly it is from male in origin. There are again subtypes. When we say androgenesis, it need not be always homogeneous. It can be heterogeneous. As I said in the previous slide, it starts with fertilization of a empty ovum, which does not have X chromosomes at all. So whatever chromosomes, it will be from the male. That's why it is called androgenesis. So maternal chromosome is probably inactivated. When we say homozygous, which is 85% of the time, it is that 23X one single sperm which will fertilize, and there can be duplication. Or it could be two sperms also, but both are XX. That's why it is called homozygous. Now, as you can see here, the fertilization gives 46XX. What is to be noted here is both the X come from father, males. That's the important thing to understand, androgenesis, because they are fertilized in an empty ovum, paternal chromosomes only. So then, of course, the cell duplication occurs. The androgenesis can be heterozygous, that is, two different sperms. One is X, other one is Y, but both, of course, paternal dispermy, we call it. Here, when you see the configuration, it looks like a perfect male, 46XY. But again, the point to be noted here is both X and Y have come from the father. That's why it is abnormal. Of course, the duplication later is same. When it comes to partial mole, it's not an empty egg, of course. There is 23X set of chromosomes. But again, the problem here is they are fertilized by two different sperms, X and Y, as we can see here in this particular case, dispermy. And the resultant will be 69XXY. Again, the problem here is the additional X and Y, of course, are both from the paternal origin. So as to say, the problem is when there is excess of paternal influence, there can be molar pregnancy. Of course, the duplication is same. So it's a triploidy, 69 XXY cells. Maternal is there, but there is dominance of additional sex chromosomes from father's side. I hope it's very clear. The clinical course, vaginal bleeding is the most common. Watery brown discharge, 84 to 97% of the time. See, in undergraduation, we simply say vaginal bleeding, that's enough. But in post-graduation, you have to say what percentage of patients will have these symptoms. So vaginal bleeding is the leading symptom. And then theca lutein cyst. Again, not in everyone, but 50% of the patients. Typically, we say in undergraduate teaching, uterine size more than period of gestation in molar pregnancy. But as a postgraduate, you must know that it's present only in 28% of the cases. Early onset of preeclampsia, 27%. Hyperemesis gravidarum, 8%. Hypothyroidism, 7%. Nice to say, but we don't see this in clinical practice. Can anybody guess why? Because we don't allow the pregnancy to go to that extent. We can diagnose them early, and when we diagnose them, we manage them. And what's the management? No secret, we have to evacuate. So the pregnancy won't last to that extent as to develop hyperthyroidism, hyperemesis, and preeclampsia. Trophoblastic embolization can also occur, which can be dangerous, but luckily it occurs only in 2% of the patients. Symptoms of missed abortion is mainly seen in partial mole because there will be bleeding, but pregnancy seems to continue because there is some half-hearted attempt of a fetus. So that's why the pregnancy will go on for some more time, but eventually it will abort. How do you diagnose? Of course, it's very, very straightforward. Though beta-HCG is high, that's what we always think, that alone is not enough because beta-HCG will be high in twin pregnancy as well and hyperplacentosis as well. So if somebody asks you, give me single investigation, it has to be ultrasound. In complete mole, in the old terminology, we used to say snowstorm appearance because the ultrasound resolution was not that good. With the higher resolution ultrasound, we can see beautiful honeycomb pattern. And on the sides, we can see theca lutein cysts. In partial mole, it's non-viable gestation and enlarged hydropic placenta. You can see, if you are lucky, you can see that fetus there. In the last minute, you can see some fetus. The rest of it is hydropic degeneration. Can you see the last minute? Yes, that's what the fetus that was being seen in the last minute. As far as hydatidiform mole, it can happen also in ectopic region. We had a case of mole in the tubal region and we have published that. Solid heterogeneous adnexal mass, which is separate from the ovary, will give you a clue. The pathological diagnosis is, of course, the final one. You can see clearly tubal hydatidiform mole, a variant of ectopic pregnancy. As far as invasive mole is concerned, again, ultrasound is the diagnostic tool. Distension of uterine cavity with echogenic material with cystic spaces. As you can see here, the arrows are showing the cystic spaces. Areas of ill-defined myometrium. So here the myometrium is not well defined. It's not very clear. Mosaic pattern on color Doppler. As you can see, once you throw the color, there will be a mosaic pattern. The choriocarcinoma is unmistakable in ultrasound. It's a heterogeneous mass, diffuse cystic pattern compared to invasive mole, increased vascularity on Doppler. There's no specific pattern. There's another picture. On histopathology, there is absence of chorionic villi. They don't mature up to that level. Presence of abnormal intermediate and cytotrophoblast, rimmed with syncytiotrophoblasts with areas of necrosis and hemorrhage. So pathologists can immediately make out this. Whenever there is necrosis and hemorrhage, they first suspect cancer. What's the management? As I told, it's not a secret at all. Immediate suction evacuation. There's no way you can allow this pregnancy to grow even maybe one day, unless the patient's condition is very poor, where you want to first stabilize it and then you want to do evacuation. Cervix is usually patulous, enough to introduce plastic cannula. Nowadays, we are not using metallic cannula. What I mean to say is there is no need to dilate the cervix. Of course, nobody does fast dilatation these days with the dilators. There is no need of even putting the misoprostol. Oxytocin drip in some centers, they do this as you are evacuating, but it is not advisable. At least it is controversial because if you use oxytocin at the time of evacuation, there's a chance of embolization. However, after evacuation, oxytocin drip is definitely useful in preventing the hemorrhage. There is no need of curettage in the same setting or after 1 week. This is the exact study I did in Charing Cross Hospital, London, and published. So that's why I'm very confidently telling there is no need of doing a curettage either in the same setting or after a week. You can do suction evacuation to the extent of 95 to 98%. Rest of it will take care of itself. Why we should not curate is because there's a good chance of perforation. This is very extremely soft uterus there. Blood products to be kept ready, it goes without saying. And Rh negative patient should receive anti-D because the moment there's chorionic substance, there will be antigen. Management of vesicular mole can be done with, should not be done rather with medical induction of abortion and hysterectomy, because medical induction will induce very strong contractions and there can be embolization. Hysterectomy is usually uncalled for. That is not at all required. Any surgery as such is avoided. I'll come to hysterectomy a little later. These methods increase the maternal morbidity, as I said, because of embolization and the development of post-molar GTN requiring chemotherapy. So it's clearly avoidable. Hysterectomy, I was telling you, hysterectomy is an alternate to suction curettage if childbearing is incomplete. Having said that, you can debate this for a whole day. I know in some of the conferences, the experts debate on this. Hysterectomy is not at all the first-line treatment for vesicular mole, at least, unless you feel that the patient is very elderly, she had many repeated molar pregnancies, hemorrhage is so much, or there must have been a perforation to control the bleeding or to save the patient's life, you can do it. Not just because she has completed family. I hope I'm clear. That's enough regarding the controversy about hysterectomy. I will talk more about it a little later. Post-evacuation follow-up is the most important thing. It's an important question even in undergraduates as well as postgraduate examination. The weekly HCG measurement until it becomes normal for 3 consecutive weeks. This is highly important. Usually, it comes down by around 63 days. Normally, the test becomes negative in 6 to 8 weeks. That's what I meant by 63 days. Monthly thereafter for 6 months, and then you can switch over to once in 2 months for another 6 months. So in the first year, first 2 months every week, and then up to 6 months, that is the next 4 months monthly, and then the last 6 months once in 2 months. If HCG has become normal, follow-up may be discontinued and pregnancy can be allowed after 6 months. What it means is that if the HCG comes down to normal absolutely after 6 months, then actually you can discontinue it, and if she wants to become pregnant, it can be allowed. So this is the typical beta HCG regression curve that we say. It comes down by 10 folds in the log of 10. So from 100,000, it can come down to 10,000, then 1,000, 100, and it just goes down like that. This is typical. Any deviation from this is not typical. So pregnancy during follow-up. Suppose she becomes pregnant during follow-up. Termination of pregnancy is not indicated if accidental pregnancy occurs during surveillance after the HCG levels have returned to normal. So it's good. It's okay if it's normal pregnancy, let it be. Nothing will happen. Data now show that it is safe to recommend oral contraceptives. When I was there, they used to hesitate to give oral contraceptives because they thought it will come in the way of interpreting the beta HCG regression curve. Now it is said it is safe. Prophylactic chemotherapy, lot of controversy again, but Cochrane database in 2017 for a change has come out with a clear guidance. It's no longer recommended as this exposes 80% to unnecessary chemotherapy. What it means is only 20%, as we have seen in the first slide itself, 15 to 20% only go for choriocarcinoma. Why unnecessarily expose 80% of the women for chemotherapy. After all, chemotherapy has got its own side effects. We all know that. If at all it is controversial, may be considered in high-risk patients when HCG is over 1 lakh before emptying. So that means at the time of diagnosis of vesicular mole, if it was more than 1 lakh beta HCG, maybe you can consider HCG regression curve is not progressively declined or it plateaus. I'm going to talk about that again, persistent trophoblastic disease. Then also probably you can consider when hormonal follow-up is unavailable or unreliable. Suppose you think that the patient won't come that weekly, monthly for beta HCG, maybe you can give one course of chemotherapy, prophylactic chemotherapy. That's the meaning of it. Uterus is obviously larger than the size of amenorrhea. Again, here you would expect a very high beta HCG because of lots of chorionic villi would be there. Again, that would ask for prophylactic chemotherapy. Finally, luteinizing cyst is more than 6 centimeters. That means again, there was a lot of HCG to give rise to so big luteinizing cyst. So I hope I'm clear about the prophylactic chemotherapy. The risk of recurrence is low, 0.6 to 2% after 1 molar pregnancy. It is same coinciding with I said 98% of the pregnancies, subsequent pregnancies will be normal. It is much increased after consecutive molar pregnancies. I told you one is to 1,000, to 100, to 70, to 7 it becomes if there are repeated molar pregnancies. Mutations in NLRP7 and KHDC3L have been reported in women with recurrent pregnancy, molar pregnancy. Now I come to the classification. We already have seen this. Now, after finishing trophoblastic, this is the complete and partial mole part. Let's go to the neoplasia part. The incidence of GTN after molar pregnancy is sometimes up to 50%, including all. After abortion is 25%, and preterm and term pregnancy, it is 25%. Well, again, in complete and partial mole, it can be lesser. In partial mole, it is more in complete mole. The clinical presentations of GTN, abnormal vaginal bleeding, same, most of them will have 90%. Bleeding from metastatic sites is now the additional clinical presentation. Pulmonary symptoms, patient will have chronic cough. Neurological signs from spine and brain metastasis if hemorrhage occurs there. And GTN should be considered in patients with unusual presentation and serum HCG. So if you think that the presentation is not fitting typically into anything, you suspect choriocarcinoma. The FIGO criteria for gestational trophoblastic neoplasia, or earlier we used to call it persistent trophoblastic disease, very, very easy. And remember this, when the plateau of HCG lasts for 4 measurements over a period of 3 weeks or longer, that is days 1, 7, 14, and 21. So first time you did, and it is lasting for 4 measurements. It's like this. Or when there is a rise in HCG for 3 measurements over at least a period of 2 weeks or more. So if it's plateauing, 4 measurements. If it is rising, 3 measurements is around 1, 7, 14. Or if it increases at 6 months or more. So you thought that everything was going down, but suddenly after 6 months, it goes up. That means there's a new activity. That is also sign of GTN. If there is a histologic diagnosis of choriocarcinoma, I must elaborate on this. Histologic diagnosis is not required to diagnose choriocarcinoma. This is the only cancer probably biopsy is not required to diagnose cancer. But suppose you have sent the curettage, or I mean the evacuated material for histopathological examination. And if that report comes as choriocarcinoma, obviously it is choriocarcinoma. The diagnostic evaluation would include HCG, of course, common for all, ultrasound, both pelvic and abdominal. If you suspect metastasis, then you have to do, lung, 80% is the time, chest X-ray and lung CT, vagina 20% of the time, speculum examination is good enough for that. Do not attempt to remove this urethral nodule. She will bleed like anything, and you won't be able to stop this. Liver, 10% of the time, CT abdomen and LFT is a must. Brain, again, 10%, CT, MRI, brain. So these are the additional diagnostic evaluation you do. Of course, it goes without saying CBC and RFT, especially when you start on chemotherapy. The prognosis depends not only on the anatomic extent, but also other factors: age, antecedent pregnancy, an interval from that, serum HCG value, starting one, number, site, and size of metastasis, prior chemotherapy, and hence there is both staging and risk scoring. Most of the cancer, almost all cancers, I would say, except the choriocarcinoma, you talk only about staging. That is the anatomic extent. You don't talk about the other risk factors. But choriocarcinoma is the one. In fact, Bagshaw and Professor Newlands, they only talked about the risk factors. They didn't actually have a staging at that time. But now, in addition to staging, we should also respect the risk factors. So that's why there is staging and risk scoring together. As I said, USCC classification was initially there 67, Bagshaw scoring came up later, then FIGO staging happened, and then it was revised in 92 and 2000. WHO scoring was there already in 83. Then we have combined FIGO staging and scoring, that is WHO scoring system in 2002, until today it is holding. So what is that? Stage 1, of course, is disease localized to uterus. Like in any other cancer, it is a localized one. Disease is localized to pelvis and adnexia in stage 2. Stage 3 is pulmonary metastasis, not very serious. Stage 4 is distant organ, that is liver, brain, kidney, and GI tract and spleen. It looks like I won't be able to complete this today. Does not matter. Let me not hurry up. I will continue tomorrow also because I already got an alert. It is very important to understand this. The WHO's risk scoring is adopted by FIGO in 2002. In fact, WHO itself adopted Bagshaw scoring system. Here, we take all those risk factors. You may not remember all this number game, but you should have this handy in your mobile or somewhere to calculate the risk in every single patient. Age less than 40, 0 marks. More than 40, 1 mark. Thereafter, it doesn't matter. So 2 and 3, it's a dash. Antecedent pregnancy, if it was molar pregnancy, 0 marks, because after molar pregnancy, you definitely anticipate a choriocarcinoma. So 0. Whereas after abortion, you don't expect choriocarcinoma. So if it happens, 1 mark. And after normal pregnancy, term pregnancy, you definitely don't expect choriocarcinoma. So if it happens, you give 2 marks. Interval months from index pregnancy. If it is less than 4 months, it's 0 because you are under follow-up. If it occurs somewhere between 4 to 7, 1 mark. After 7 months, you don't usually expect it to happen. If it happens, 2. And after 1 year, though, you actually would have forgotten. And if it happens, it gets high marks, 4 marks. Pre-treatment HCG is very important. If it was less, 0 marks. 10 to the power of 3 to 4 is 1. 10 to the power of 4 to 5 is 2. Anything more than 10 to the power of 5 is 4 marks. Largest tumor size, including the uterus, less than 3 centimeters, 0. 3 to 5 is 1. More than 5 is 2. Thereafter, nothing. Site of metastasis, as I told you, very important. Lungs is not so serious. I have been telling this repeatedly in this lecture. So that's why 0 marks. spleen and kidney 1, GIT is 2, look at liver and brain, 4 marks. No metastasis, or rather number of metastasis, if it is just less than 1 maybe, or just there, it is 0 marks. 1 to 4 is 1, 5 to 8 is 2, more than 8 is 4 marks. Previous failed chemotherapy, somebody has tried it, it was not failed, then 0. But if it was single drug failure, 2 marks, and multiple drug failure, 4 marks. Now, when you put all these things and then you have to total, the total, if it is 0 to 6, it's called low risk. Staging is one thing. In addition to that, low risk or high risk should be also ascertained. Where did middle risk go? The moderate risk is not necessary. I asked this question to Bagshaw. He said, because the treatment for moderate risk and high risk is not very different. So they have just made low risk and high risk. Anything more than 7 would be high risk. The combined FIGO staging and scoring, it goes like this. If it is low stage, which is stage 1, 2, and probably sometimes even you can take 3. And if it is low score, an example I'll give you, 42-year-old, 9 weeks post-evacuation, ultrasound shows addexa is free, HCG was just 10,000, no metastasis at all. Let's see how do we place them. 42 years, of course, 1 mark. Antecedent pregnancy was a mole, so 0 marks. Interval from index pregnancy, it was 9 weeks, that is less than 4 months, 0 marks. Pre-treatment HCG, 10,000 only, that is 10 to the power of 3 to 4, 1 mark. Largest tumor size including uterus less than 3 centimeters, so 0 marks. Site of metastasis was actually no metastasis, so everything is 0 there. So totally here you can see, because only uterus is involved, it is stage 1. And if you total up, you get only 2 marks here. So low risk. This is how you always score a patient, both stage and score a patient. I'll give you one more example of high stage and high score, and probably after that I'll stop this class. 41-year-old, 7 months post-delivery, mass of 4 centimeters, HCG 100,000, 2 liver mets. Let us place this. So age is 41 years, so more than 40, 1 mark. Antecedent pregnancy is a delivery, term delivery, so 2 marks. And the interval from 7 months, so it is 2 marks there again. Pre-treatment HCG was 100,000, 4 marks. And largest tumor size is 4 centimeters, 1 mark. Site of metastasis is liver, 4 marks. Number of mets, 2, 1 mark. So what's the total score? Here it is 1 plus 2, 3, and 5, 9, 10, 14, and 15. So as you can see here, it is stage 4 because liver mets are there, distant metastasis, and it is high risk because total score is 15. I hope you understood. Staging plus scoring, both are important in order to decide the treatment of it. So I will talk about the treatment tomorrow because I don't want to hurry up and make it clumsy. Thank you very much. See you tomorrow again at 7:30 sharp to know the treatment of gestational trophoblastic neoplasia. Bye and good night.